Hello, everybody, and welcome to NESA MP. It's Dr. Rojas here, and I am here to discuss the pulmonary module. In this channel, I give you all of the information you need to be successful in your school and prepping for certification. My method of teaching is consistent, and all disease slides will have certain things in common. I will discuss what the disease is, the primary risk factors, the causes, manifestations, diagnostics, specifically GOLD diagnostics, and the first line treatment. At the end of each module, I will have a fast fact slide with additional information on hot tips to know for examinations. And this includes diseases that we have covered and diseases that we may not have covered within the module. So let's go ahead and get started. The first topic is something that is a bit difficult for students and, future nurse practitioners to understand sometimes because it can be confused with other types of pneumonia. However, community-acquired pneumonia is the one that we're going to be focusing on specifically for a primary care outpatient setting, correct? As family nurse practitioners, this is the one that we often see more. So let's go ahead and jump in. Community-acquired pneumonia is an acute infection of the lungs acquired outside of a hospital setting, and that's the key word, outside of a hospital setting. It's marked with inflammatory changes and damages to the lungs. Risk factors include being older in age, plus 65, comorbidities, respiratory tract infections, and of course smoking. Causes, the two main causes will include strep pneumo and H influenza. And the manifestations will be acute in nature. So acute onset, fever, cough, usually productive in nature, pleuritic chest pain, and of course fatigue. Diagnosis will be based on our GOLD diagnostic, which is a chest x-ray. And it's important to understand, that there are other diagnostic procedures out there, but the gold standard is what the exam is going to be asking you about. And in the case of pneumonia, you have to understand that a chest x-ray will be the go-to, not a sputum culture. That's different, right? That will be for tuberculosis. So for pneumonia, it's going to be the chest x-ray. And look out for keywords on your examinations. Whether you're taking the AAMP or the ANCC, you may see keywords that mark this disease process and nothing else will be of similar nature. So for pneumonia, the keywords for diagnostics will be lobular consolidation, interstitial infiltrates, and cavitations. So make sure that you highlight those and that you understand that those are specific to community-acquired pneumonia. The treatment will depend on the presentation of the patient. So in the case that the patient has no current comorbidities, meaning that they don't have any other attributing disease, you will do one of three medications, so monotherapy, doxycycline, a macrolide, or amoxicillin. And do you see how amoxicillin has a little star next to it? That's because it has the highest evidence and is the best choice out of the three for those who have no comorbidities. Let's say the patient has a penicillin allergy. Well, then we would still have two other options, right? Doxycycline or a macrolide. However, amoxicillin will be your very first line. For those individuals who have comorbidities, we have two different pathways that we can take. We can have pathway 1, which is a respiratory fluoroquinolone, or we have pathway 2, which includes a combination therapy. So doxycycline or azithromycin plus augmentin. So the first treatment option for somebody who has comorbidities will be a singular monotherapy treatment with a fluoroquinolone. And the second treatment option for somebody who has comorbidities will be combination therapy. So doxycycline or azithromycin plus augmentin. So know that, right? For pneumonia, I also want to discuss CURB 65. This is used to assess whether patients can be treated in an outpatient setting or in an inpatient hospital setting. So let's go over the mnemonic. So CURB 65, CURB 65. Each has something that stands for each letter. So C stands for confusion. U stands for a BUN of over 19.6. R stands for respirations over 30. B stands for a blood pressure less than 90/60, and 65 is 65 years of age. If the patient meets the specific guideline, it's a +1 point. A total score of 1 or less indicates that the patient can be treated in an outpatient setting, while a score of 2 or greater indicates that they must be hospitalized. In addition, if the patient presents with acute confusion or severity and other comorbidities, then of course they would want to be treated in a hospital setting. So remember, C for confusion, U for BUN, R for respirations, B for blood pressure, and 65 years of age, all right? It's important to know that for pneumonia. Based on a quadruple therapy, so rifampin, isoniazid, pyrazimide, and ethambutol, otherwise known as RIPE therapy. Righty? For tuberculosis, it's also important to know when iterations on a PPD can be considered positive. So let's walk through that because you must know this for your exam. There are 3 readings, and certain populations fall under each one. So a reading of 5 mm's will be considered positive if the patient is HIV positive, is immunocompromised, or has had recent exposure. A reading of 10 mm's will be considered positive if the patient is an immigrant, is homeless, or is a healthcare worker like you and I. And a reading of 15 mm's or higher will be considered positive for the general population, those who have no other risk factors. Ready? So know this, 5, 10, 15. Listen to this over and over again until you're able to understand this. So here you can see that these are lungs, obviously. And I want to highlight this because it's important to know the difference between pneumonia and tuberculosis, right? And the manifestations we've reviewed, but where the lung is affected is different for tuberculosis and pneumonia. So where do you think tuberculosis will present? The upper lobes, the middle lobes, or the lower lobes? Yeah. Tuberculosis usually presents in the upper lobes, and that's important to recognize because the examination, whether you get a chest x-ray if you're taking that specific test or you get it described to you, if they're talking about an infiltrate or a consolidation in the upper lobes, then we know immediately that we're discussing tuberculosis, right? And we can rule out anything that has pneumonia as an answer out, as opposed to being affected in the lower lobes. This indicates pneumonia. So if the examination question is talking about a lower lobe infiltrate cavitation, any word that indicates that the lower lobe is affected, then we know that most likely it's going to be pneumonia. So know this. It's important to remember this. Ready? Now let's move on to something that's not so severe. The chest x-ray will most likely be benign or is benign, and that's important, right? Because in the previous 2 disorders, pneumonia and tuberculosis, the lungs are not benign. So tracheobronchitis or acute bronchitis is an acute condition where inflammation of the lower respiratory tract occurs. It's most likely viral in nature. However, it can be caused by a gram-negative bacterium, Bordetella pertussis, which is when we would treat it with a bacterial medication, right? So the risk factors include upper respiratory tract infections, smoking, pollutants exposures, allergies, being very young, right? Less than 6 months usually, chronic lung disease, and season and environmental changes. So we usually see acute bronchitis come about during the season changes, right? Like I said, it's most likely viral, but when it is caused by a bacterium, we worry about Bordetella pertussis, which is gram-negative. There are 3 stages that you must know for acute bronchitis: catarrhal, paroxysmal, and convalescent. The manifestations will include a cough times 2 weeks that has post-tussive vomiting. That's important. This is key for acute bronchitis. Nothing else will be described as post-tussive vomiting that is hacking, all right? So a hacking cough with post-tussive vomiting, or you cough so much, so hard that it makes you vomit afterwards. Diagnosis is pretty non-specific. You can do a CBC, you can do a chest x-ray, which should be benign, right? If it isn't benign, then we can rule out this or think that there's maybe something else happening at the same time, and we can do a PCR or a swab. However, the important thing to know about tracheobronchitis is the treatment. So when bacterial, we can choose a macrolide, but we also want to be supportive in nature, right? So antitussives, mucolytics, rests, and fluids. This is acute infection that is spread via droplets. So we want to make sure that we protect everybody around the infected individual. And we often see it in those who are less than 6 months of age. So again, a lot of the treatment that we're going to be providing is therapeutic in nature, making sure that they don't dehydrate, making sure that they're drinking lots of fluids. Ready? Alrighty, so asthma is the next disorder that we're going to be talking about, and asthma and COPD are also going to be next to each other because oftentimes it's difficult to understand the difference between them. But let's not make it more difficult than it needs to be. Remember that I give you everything that you need to understand the disease and be able to appropriately diagnose and treat individuals in clinical practice. So asthma is reversible in nature, and it presents with chronic increased airway hyperresponsiveness and recurrent airway obstruction and inflammation. Risk factors will include any respiratory conditions such as upper respiratory tract infections or lower respiratory tract infections for that nature, more chronic disorders such as COPD, allergens, smoking, atopic disorders, right, because asthma is considered one of the atopic disorders, exercise, or change in weather. The manifestations that patients most often present with will include chest tightness, shortness of breath, tachycardia, tachypnea, wheezing, hyperresonance, decreased exercise tolerance. These people feel like they can't breathe. It's difficult to really be active in their daily activities because they feel like their chest is very tight. The diagnosis will be based off of spirometry, and we would like to see an over 12% increase or over 200 ml improvement with the FEV1 after treatment of a SABA or being on an ICS for 4 weeks. And the treatment is very step-like and has many options that we can choose from depending on the severity and the symptomology that the patient is presenting on. So step 1 and 2 is usually PRN in nature. However, we can move on to a lower maintenance therapy in step 2. Step 3 and 4, we increase that maintenance therapy. And then step 5, we definitely should be referring out if we hadn't in step 4 yet. The treatment guidelines that you can see on this slide are based off of GINA 2023. These are relatively new guidelines. Asthma guidelines hadn't really been changed in a couple of decades, so it's important that we really understand them, okay? Previously, our reliever therapy was albuterol. However, research has shown that an ICS formoterol combo is more efficient and actually decrease more death in individuals with asthma. So that is what the new guidelines really focus on. It's important to also understand the difference between asthma and COPD that we're going to talk about next. Asthma is reversible in nature, as you can see on the slide, and the treatment is very step-like. That's why you have steps 1, 2, 3, and 4, 5. COPD, on the other hand, is irreversible, takes decades to occur, and the treatment is not step-like. It's critical to ask the patient about their history. When did the signs and symptoms present? What exacerbates it? What makes it better? Any history of atopic diseases like allergies or atopic dermatitis will also be important when we're talking about patients with asthma. Okay. So, Asthma GINA 2023 guidelines are what we're going to be talking about on this slide. And please don't let it confuse you. It's very simple once you get it down. And what I recommend for anybody who's having issues with medications or treatment options is to use flashcards. Write this slide over and over and over again on a flashcard until you know it sleeping, until you know it with your eyes closed. If anybody were to ask you, you know what it is. Ready? So steps 1 and 2 indicate that the patient is having very few symptoms, usually, less than 2 to a little bit more than 2 times a week. However, it's not really affecting their life that much, and they definitely don't have symptoms during the nighttime. For this step, or for these 2 steps, 1 and 2, we're going to offer ICS formoterol PRN for step 1 or ICS formoterol combo in low maintenance for step 2. Do you see that? It doesn't really change. We go from PRN to maintenance. Step 3, the symptoms are becoming a little bit more bothersome. They have signs and symptoms most days of the week, and they're waking at least 1 time per week due to the asthma symptoms. So what we do here is we increase their maintenance therapy. So I see it as formoterol low or medium. Ready? And then step 4, they're having symptoms most of the day and definitely more often than they would like to at night, and we're seeing low functionality in this step or this specific area of the disease pathology. So we increase their ICS formoterol maintenance to a medium or a high, but really step 4 is where we should begin to consider perhaps referring out. Righty? The previous slide also mentioned step 5. However, I'm not even going to discuss it because this is definitely somewhere or a step that you should be referring out and keeping them on the step 4 therapy, but definitely referring out to individuals who can focus more on managing the asthma. Righty? And it's very unlikely that you'll be asked about step 5 on the examination. There's also a second track that GINA 2023 offers, and the difference is that the second track in step 2, instead of doing the maintenance low dose combo, you would do an ICS alone as maintenance with a short acting as PRN. However, remember that I talked about knowing your first line treatment versus other options. Your first line treatment is going to be what's on this slide. So steps 1 and 2, we can do PRN on low maintenance and ICS formoterol combo. Step 3, we bump up that ICS formoterol combo. Step 4, we bump it up even higher, and we should be considering referring out. And I hope that makes sense. Ready? So moving on to COPD. COPD is irreversible pulmonary disease that's chronic and progresses to pathologic changes in the airway and the alveoli. Okay. Risk factors include smoking, occupational pollution, and older age. Remember, this is a disease that usually presents later on in life because it takes decades to manifest and to do the damage to the lungs that's needed for the symptomology to begin to occur. The causes can be risk factor related, like I mentioned above, or genetics. Less than 1% of those affected with alpha-1 antitrypsin deficiency can have COPD, so we would want to keep that in the back of our minds. Manifestations include persistent worsening dyspnea, coughing and sputum, increased resonance, decreased breath sounds, wheezing, crackles, distant heart sounds, and barrel chesting. And the reason the heart sounds are distant is because our AP diameter is getting wider, which means that it's actually becoming difficult to hear heart sounds. Ready? Diagnosis, again, is based on spirometry. However, in asthma, we base it off of the FEV1 alone. For COPD, we're going to be basing it off of the FEV1 FVC ratio of less than 70% post bronchodilator spirometry. So remember, asthma, FEV1 alone, COPD, FEV1 FVC ratio, righty? And the key number here is less than 70%. And for COPD, the treatment is not step-like. There are 4 methods of treatment, however, not step-like, and I want to emphasize that. All right. So step 1, or the first option that we have, is a SAMA or a SABA. However, research has shown that a combination will be better than each of these alone. So a SABA or a SAMA, or together PRN. Step 2, or number 2, will be a LABA or a LAMA, and again, the same thing applies here. Combination will always be better than individualized. The third one will be an ICS plus a LABA or a LAMA, and it doesn't really matter which one. Is it a LABA or a LAMA, as long as the ICS is on board. And the fourth one will be an ICS and a LAMA and LABA. So usually how it works, what we often see treatment-wise is a SABA, then we move on to a LABA, then we move on to the ICS and the LABA, then we move on to the ICS and the LABA and LAMA. So you see that we're increasing the amount of medications that we're giving them. COPD has 3 characteristics that we should really know because they shout COPD, all right? Dyspnea, chronic cough, and chronic sputum. So those are the 3 indicators of COPD that we should really be watching out for. COPD is more generally composed of 2 disorders, emphysema and chronic bronchitis. We used to really differentiate between the 2. However, now we know that they both usually co-occur. So that's usually how we define COPD, righty? But generally, emphysema is manifested with weight loss, barrel chest, pursed lips breathing, and hyperresonance, while chronic bronchitis is manifested with cyanosis, mucus production, hypoxia, and the cough, right? So emphysema will not have that cough that we usually like to associate with COPD, but chronic bronchitis will, right? So just know that in general. You don't pay too much attention to it, but just know that it's made up of 2 disorders. Ready? Pulmonary systems fast facts. So this is the slide that I talked about, that in each of my presentations I have a fast facts PowerPoint where we discuss must know clinical pearls for diseases that we've talked or diseases that we haven't talked about in relations to the system that we're talking about. Ready? So the very first one that we're going to be discussing is pneumococcal vaccines. We like to talk about PCV13 and PPSV23, and it's usually given, or these vaccinations should be offered generally to those over 65 years of age. PCV13 and 15 are recommended for children younger than 5, and other children can also receive it if they have certain medical conditions that place them at an increased risk. For adults, PPSV23 is recommended for those over the age of 65, and if they have one, we usually want to give the other at least a year apart. So if they come in and they only have PPSV23, then we would want to wait a year and then give the PCV13. If they have the PCV13 only and not the PPSV23, then we want to give that we want to give it a year later. Ready? Breath sounds I want to talk about very, very briefly. I would hate for you to miss a question on your exam because you didn't know what they were referring to. So vesicular breath sounds are heard at the base. So think vesicular sounds like kind of like bass, right? It's very soft, it's very blowing because it's far away. So it's very gentle in nature. Then we have the bronchial sounds, which are heard over the bronchi, right? And they're a little louder because they're closer to where we're listening, but not as harsh as the tracheal breath sounds, which are heard over the trachea. For examination, we have a couple of different tests that I just want to talk about. We have egophony, which is where you have the patient say something such as the letter E, and it sounds like A. So they'll say E, and when you're listening to it, it sounds like A. And it's due to an increase in fibrosis or consolidation in the lungs. And that's not normal, right? We don't want consolidation or fibrosis in the lungs. So that would raise our flag that maybe we need to do a little bit more assessing. Right? Then we have whispered pectoriloquy, which is increased loudness of whatever was whispered with auscultation. So have them whisper, I don't know, something like 99, right? And it'll be an increased loudness because we're hearing the fluid or whatever is in the lungs kind of serve as an amplifier of the sounds. Ready? And then tactile fremitus is where there's when we feel the lungs, like you're sitting behind you're standing behind the patient and you feel at the lungs, you're going to feel an increase in vibrations because of the fluid in the lungs. So remember that fluid is a really good amplifier for sound, so we feel a lot more of the vibration. Ready? Then lastly, I want to talk about lung cancer. And the most indicative sign usually that we may have to look at when we suspect lung cancer is a chronic cough that persists, right? That's important to know. That's important to ask. Ask your patients, when did this cough start? If they tell you, it's been present for years and it doesn't go away, that's a red flag that we maybe want to look into it a little bit more. Ready? And under lung cancer, I also want to discuss Horner syndrome just a little bit. Just keep it in the back of your mind. If the patient presents with a pupil that's constricted with ptosis, we definitely want to look at the respiratory system a little bit more. Ready? So consider asking about smoking, about family history, about where they worked, right? Working in a mine is definitely going to be a higher risk factor than working in an office space where smoking isn't allowed. We just have different risk factors there. So keep in mind the chronic cough that persists and Horner syndrome for lung cancer. I hope this module was helpful. Don't make it more complicated than it needs to be. My content reviews what you need to know to pass and gets rid of all of the excess fluff. That excess fluff is definitely going to be important for your clinical practice. However, the exam cannot test you on the hundreds of thousands of disorders out there, right? It focuses more on what is most common and what we definitely will see in clinical practice. And all of the disorders I talked about today, acute bronchitis, asthma, COPD, tuberculosis, and pneumonia, you have to be able to recognize. And please always remember that you will pass. Thank you so much for joining me today.